Gerson. So Dr. Gerson is the director of the Children's Comprehensive Psychiatric Emergency Program, or CCPEP for short, at Bellevue Hospital. She's also a clinical assistant professor in the Department of Child and Adolescent Psychiatry and the associate director of Child and Adolescent Psychiatry at NYU Medical Center. As some background, Dr. Gerson received her bachelor's at Harvard University and received a medical degree here at Columbia University. And she completed her subsequent clinical training at Cambridge Health Alliance, affiliated with Harvard Medical School, as well as the Child Study Center at NYU Med and Bellevue Hospital. Speaking to Dr. Gerson's research interests, she has a number of different interests ranging from program development, systems of care, and outcomes research with traumatized youth and social emotional development. She specializes in caring for children and teens experiencing mental health crises such as suicidal thoughts and behaviors relevant to her talk today, and as well as the new onset of psychosis. Dr. Gerson has authored numerous articles and has presented nationally, including at the American Academy of Child and Adolescent Psychiatry conferences, and elsewhere on the impact of bullying on child mental health and on improving systems of care for traumatized youth. On more of a personal note, Dr. Gerson is currently a collaborator with our lab here at TC on a study taking place down at Bellevue Hospital at CCPEP on youth suicide risk. So I'm very excited to have Dr. Gerson today. Just join me in welcoming her.
And I'm really sorry for our lateness. I promise we left on time, but then had traffic problems. My husband would say that sounds like an excuse, but I swear it's true. Olivia can attest. Okay, so I'm going to somehow put this onto my person. Is it working? Do I have to turn it on?
It's already, Emily, do you know?
Now I think it's on.
Yeah, it's on.
Is this the right one? Yeah.
Okay.
And then this is the clicker. All right. So we are going to talk today about suicide risk in adolescents and how we think about it clinically. And if people are interested in talking more about the research that we do in CCPEP, we'll be happy to talk about that stuff as well. We can talk about really whatever is of interest, so feel free to interrupt with questions. I can't really tell if this microphone is working.
Yeah, the speaker's back there more for the video than...
Okay, but you guys can hear me fine. Okay. I'm a congenitally loud person. So, this is here. It'll be in my armpit.
But you can put it in your collar, like...
Oh, that's a good Jeez, the brain's behind the operation. Much better. Microphone in my armpit. So good. All right. Now let's see if I have better luck with the clicker. There we go. Okay. So, just as a moment of backstory, then I'll talk about this. So, the Child Psychiatric Emergency Room at Bellevue Hospital is a specialized emergency room just for children's mental health. And I have found when I go to, like I've done some advocacy work, so like if I go to Capitol Hill or if I'm talking to donors or things like that about why we need an emergency room for children's mental health, they're like, why would children need help with that? Like, why would children be sad? So I always like to open my slide with just a little bit about the statistics of this. You guys probably know this already, but suicide is a very important issue for adolescents. 1 in 12 high school students attempt suicide each year, and 1 in 5 say that they've seriously considered suicide in the past year. And I think those numbers also reflect the importance of the kind of work that Christine does, trying to figure out how do we catch kids at the point of thinking about suicide before they get to the point of making a suicide. We as a nation are doing particularly bad compared to other places about suicide. This is a slide from one of our other collaborators, Edwin Bernie, that looks at how the US is doing compared to other countries in youth suicide. And our youth suicide rate is about twice that of other countries. So we can think about why that might be, things around access to services or stress or whatever it is. But it's the third leading cause of death for young children and the second leading cause of death for ages 10 to 24. And while we have as a society done a pretty good job about lowering rates of accidents and childhood illnesses that otherwise used to kill children, we have really not done that for suicide. Instead, the suicide rate has increased significantly. So we'll talk a little bit about clinically when and why we should worry about kids. One of the other things that I often find when talking to even to parents is that people think that people who are at risk for committing suicide are going to look depressed. And it's important to know that looking depressed means something different for children and adolescents than it does for adults, but also depression is not the only risk factor for suicide. So we'll talk a little bit about that. But a lot of kids experience suicidal thoughts in the context of irritability, in the context of anxiety, in the context of trauma, in the context of disruptions in their social routine, so breakups or stress in the family or parental divorce, things like that. Sleep is a huge issue for suicide risk, so we always tell parents to look out for that. And then also we encourage parents to look at drug use and risky behaviors not just as a naughty thing that children do or a bad thing that children do, but rather as a marker of distress, because we know that a lot of kids who are engaging in those behaviors are also engaging in self-harm that they may not be disclosing or experiencing suicidal thoughts. A lot of kids who are aggressive to other people are also experiencing thoughts of aggression towards themselves. Those kids typically get missed because they get seen as bad or angry instead of kids who are sad and hurting. And we encourage families to look at the things that people are saying, the things that kids are saying. So when kids talk about feeling like they're a burden on their family, feeling like they're not good enough, feeling ashamed, feeling ostracized, those things are something we take very, very seriously, even if it's not happening in the context of, a 2 or 3 week period of depression and loss of interest and DSM. We worry a lot about our ethnic and sexual minority youth because we know that experiences of discrimination create stress, which leads to suicide risk. I think this is something that we're, as a field, slowly sort of getting a better handle on and having more awareness of this. I think it used to be thought of that suicide was like a white female thing, but it's not, right? This is something that affects youth of all different backgrounds. Again, I think that a lot of the, I think that some of the idea of suicide as a white female thing is about who seeks help for suicidal thoughts explicitly, being like, hi, I'm feeling sad and suicidal, I want help with it, versus who is manifesting that hurt and that need in other ways, like kids who are aggressive or kids who are using drugs or engaging in other kinds of risky behaviors. So you can see a little bit about ethnic minority status in that slide, and then here, the risk for LGBTQ youth. All of you guys are young, so I probably don't have to explain what cisgender means, but we put this is from a recent paper. The original paper didn't have here the rates for cisgender female and cisgender male, but I put it there just to show the relative increase, because I think it's really important to know the risk not just for trans youth, but for youth who are questioning, youth who consider themselves to be non-binary. I think our psychiatry is realizing that trans kids are at risk, but I think miss the whole rest of the gender spectrum, unfortunately. Definitions, I'm sure you guys know this already, but it's important nonetheless. So we like to distinguish between suicidal ideation, intent, method, and then thinking about lethality, which is separate from either intent or ideation. I think this is particularly important because if we think about this from a risk assessment perspective, if I see a young child who has a high level of intent with a low lethality method, I'm still really worried about that kid because they may just not be mature enough to know what's really dangerous, but that intent is there. That's still really worrisome. On the flip side, if I have a kid who is very impulsive and does something with high lethality but without much intent, I really worry about that kid too, because they're having impaired decision making and putting themselves in harm's way, even if they are under lethality. The other piece that's important is to recognize that a significant proportion of kids, have attempted suicide without really having made plans or described plans before that. So it's important to do safety planning, which we'll talk a little bit about later, even if kids don't have a plan in place. Not having a plan is good, it's not sufficient. So we think a lot about, in the CCPO, we think a lot about methods. Happily, there's not a lot of guns in New York, but there are guns in New York. Because guns are one of the highest lethality methods. And it's, if you're interested, I think it's interesting to look at like internationally the differences of like what kinds of methods are available in different places. But we love guns in America, so that's what we've got. We also love pills, so we have lots of those in our homes. We don't have great safety mechanisms. I remember reading somewhere that some country had put Tylenol in blister packs and suicide rates went down. We could choose to do that if we wanted to not be able to buy like 700 pills of Tylenol at Costco or whatever. But we don't do that, and then unfortunately Tylenol overdose is a very high lethality method that a lot of kids have access to because we have lots of Tylenol. Hanging and suffocation is another big one in terms of high lethality, which is really hard to safety plan around because you can hang yourself on almost anything, and it's very high lethality. So we ask a lot about access with youth. We ask about access to high places. That's another one in New York City that's an issue. Are these kids who commute by themselves on the train? Things like that. It's always important to ask about access to lethal means. Self-injurious behavior is not the same as suicide, but we always worry about suicide because it's a marker of distress associated with a wide range of psychiatric and non-psychiatric problems. And I like to think about self-harm as a behavior that has meaning, and it's our job as the adults to figure out, or to help the child figure out, what is the meaning of that behavior. If you think about it with that context, it gives you lots of places to intervene. You could think about suicide in the same kind of framework, and we'll get to that a little bit later. But if you think about self-injurious or suicidal behaviors as a thing that comes out of nowhere, I have kids sometimes who say, well, I'm just addicted to cutting. Then there's something you can do, right? Like, if it's a thing, if it's like the spirit comes over me and I'm cutting all of a sudden, there's not much that you can do about it. But if you think about it in this context, right, like if you have risk factors are things we can work around. If there's contextual factors, like if I forget to eat lunch today, I'm going to be more stressed and then more likely to cut, then we can make a plan to make sure you have lunch every day. If missing your meds or experiencing reminders of trauma or things like that, that's all stuff that we can plan around. And same thing with reinforcers. I'm going to go a little quick because we're low on time, but I can talk about more of this stuff at the end. So what do we do in terms of assessment? It does require some time and sensitivity, which is a challenge in the emergency room. We are lucky to have a specialized emergency room, which means that we have a little bit more flexibility in terms of time to engage kids. There's a lot of push for suicide screening in emergency rooms, which I think is incredibly important, but challenging then for those who have to figure out what to do with a positive screen, because if you don't have the time or the skill to be able to engage a youth in talking about something that honestly is like pretty hard to talk about, I think that can put both the clinicians and the kids in a difficult situation. But when I talk to other ER doctors about this, we frame it as, take a couple minutes to try to get to know the kid, to try to, don't open with, I read that you were suicidal, would you like to tell me about your deepest, darkest secrets? Because that's probably not going to go well, right? And also that the more relaxed and comfortable that we are, the more that makes the youth feel at ease in talking about something that they aren't sure if adults are going to be okay with this, right? If a kid starts to talk to you about suicide and they see that you're tense and they see that you have this look of like consternation or concern on your face, which may just be about like, oh God, I'm really worried about this kid and what am I going to do and who am I going to call and so on and so forth. Your mind is opaque to them, right? They don't know what you're feeling, so they may see that as, oh God, she's upset by this thing that I said, she doesn't want to hear it, she thinks there's something wrong with me, and then that shuts them down. So just trying to be as relaxed and curious and empathic as possible. Things not to do, freak out. I'm amazed at how many people will disagree with a child. This is something I talk a lot with families about. No, honey, you shouldn't feel that way. We love you so much. You have so much going for you. You're so wonderful in X, Y, and Z way, which is like, sure, true, well-intentioned, right, means to help, but I'm sure all of you guys have had the experience when you feel crappy about something, and someone's like, oh, you're wrong to feel that way, feel this other way. That feels worse. And people do it in a well-intentioned way, but when someone is really struggling, they don't necessarily want you to solve their problem or reassure them. They want you to just be there with them in that feeling. Putting aside that desire to reassure, to fix, to comfort, and just to listen is something that families and even some clinicians have a really hard time with. Similarly, jumping to problem solving. Oh, I'll talk to that teacher. Is it because of bullying? I'll deal with the bullying. There's a time and a place for all of those things. But at first, it's just to sit with the kid. When people shy away from the word suicide, we worry about that because, again, it sort of transmits to the kid that you're not really comfortable talking about this if you're not comfortable using the word. And then again, screening is plus minus. It is useful as a screener. It is not useful or is not sufficient as an assessment. So instead, empathy, normalizing, curiosity, staying calm. I also think it's really important we put on here conveying authority. Kids are probably scared by what they're experiencing, and they want to know that you're going to be there with them through it. Even if it's, it's not necessarily like, I'm going to solve this problem for you. I'm going to make sure that you don't feel like that anymore. But just like, this is something we hear a lot from kids. I know the right people to talk to. We're going to figure it out together, and conveying that, like, I'm the grown-up. We're going to be okay with this. Because they don't know, right? Kids want to be in charge, but they also don't want to be in charge. It's terrifying. And transparency. A lot of people, even in the emergency room, wonder if we have to tell this kid, I'm going to tell your parents, I'm going to, send you to the ER, I'm going to make you stay in the hospital, whatever, like, the kid's going to be so mad at me. Well, sure, they might be, but tell them why. Help them understand the reason for your behavior. People get mad when you lie to them. People get mad when you deceive them or when they feel like you're not giving them the full picture. So the more that we can be transparent with kids about, this is why I'm worried, this is what I'm thinking about. I have probably daily conversations with kids where I say, your being admitted to the hospital is not predicated on your telling me that you don't have suicidal thoughts anymore. That actually makes me want to keep you in the hospital more because I'm suspicious that that might not be real. Your leaving the hospital is predicated on your helping me think about what causes those thoughts and what's actually going to work for you to manage those thoughts after you leave the hospital or while you're here or both, and being able to be more open about what those thoughts are like, how bad do they get, how chronic are they. That's the stuff that's going to help me feel safe with you leaving the hospital because I feel like we have a transparency about that. It feels counterintuitive, right? People want to be like, I'm great, I'm fine, everything is fine, all my problems have been solved. But we also recognize that that's sadly not how the world works. I don't know the contexts in which you guys would be seeing kids or potentially asking about suicide, but I generally would recommend not to worry alone. Use your teams, use your supervisors, use your colleagues. And that helps to think about your risk assessment as well, because if there are other people also worrying about this kid, that kid is probably in better shape because there are more people involved. If you're the only one, if the parents are like, there's no problem, if the school is not particularly engaged with the kid or not connected, all of that is going to be much more worrisome. Also, how worried is the kid? Is the kid like, yeah, those thoughts were really scary and I don't like them? Or they're like, no, that's fine. That's normal for me. I feel them all the time. It's not a big deal. If I was going to kill myself, I would have done it already. All of that kind of thing makes you much more worried. So I'll take a moment to talk about the interpersonal model of suicide, which is a theory from Thomas Joyner that I really like because it helps me to think about imminent risk versus chronicity of risk. So one of the problems in suicide research is that there's a lot of talk about, sort of as they did, about like what are the risk factors, right? So let's say we say that LGBTQ youth are at risk for suicide. What do I do with that as an emergency room clinician? Does that mean that every LGBTQ youth that comes through my door needs to be admitted? For how long? Forever? For the rest of their life? Like, that tells me nothing about their risk over time. And the interpersonal model of suicide attempts to look at risk over time and to look at what makes someone at imminent risk for suicidal behavior, not just the thoughts. It's a theory, it's not perfect, etc., but I think it's a useful structure. So the idea is that perceived burdensomeness, so what I was saying before about kids who say, I'm a burden on my family, they have to worry about me so much, I'm constantly talking to my friends about how depressed I am or how anxious I am, and I feel like they're getting sick of hearing it from me. That's a huge risk factor. Kids who experience thwarted belongingness, so that could be bullying or ostracization at school. Cyberbullying is really big for this because it's the kind of bullying that you can never escape. So that creates a risk, but then another key part is the acquired capacity for suicide or fearlessness about death. So there's lots of ways to become fearless about death. One is using drugs and alcohol, which makes you pretty fearless about lots of things. But also behaviors that either reduce your experience of pain or get you used to pain. So Arjulinda, when she talks about this, likes to use an example of a very sad case of a very serious athlete who was like an Olympic athlete, I forget what sport, but was someone who clearly was able to push her body through things that were really physically uncomfortable. And when she killed herself out of the blue with no prior history of treatment and no one knew that she was struggling, she used an incredibly high lethality method. Thinking about that in the context of this is someone who, when she has set her mind to something, she has been able to do it even if it feels really difficult for her body. And she did the same thing in her death. So recognizing that youth who are engaged in those kinds of, people who are boxers or people who are serious athletes. The other one is self-injury, right? The more that you're self-injuring, the more used you get to hurting your body. That's, at least in this theory, part of why self-injury is a risk factor. The other thing I always like to point out is the impact of trauma and maltreatment. Another way in which people can get used to pain in their bodies is having people inflict pain on their bodies. So if you're a child who has grown up being hit frequently, being hurt frequently, particularly when you are crying, the parents or whoever's hurting you is saying, stop crying, that doesn't hurt, you're being a baby, you learn not to listen to your body when your body experiences things that are hurtful. Kids who've been sexually abused are incredibly high risk for suicide, and I think this might be part of it. And also the thwarted belongingness. Emotional maltreatment and neglect are very big risk factors for suicide, and it may be because it makes people feel like there isn't anyone who is there for them. We also think about, it's hard to see with the little boxes around inhibitors and facilitators of suicide risk. So things like, are there religious beliefs, or are other people monitoring, or things like that might stop somebody, versus if they're alone, if there's methods available. Thinking about crisis intervention, if you're worried about somebody, don't leave them alone. Make sure that they're in a safe space and utilize any other supports that are available to you, either emergency rooms or other options. Safety planning is really important. It's amazing to me how safety planning gets misused, even in hospitals. We have lots of kids who are discharged from the hospital, and we say, okay, great, what's your safety plan for when you really think you're gonna kill yourself? And they're like, I will take deep breaths. It's like, that feels like a nice thing for if you stub your toe maybe, but not for I'm like this close to killing myself, right? You need something stronger for that. I think as a field we have struggled with this idea of coping skills, which are not this like omnibus thing of like any coping skill can be used in any situation. Some coping skills are stronger than other coping skills. Some coping skills work for anger, other coping skills work for sadness. So the safety plan should really be connected to understanding what are the things that lead up to those suicidal thoughts and what coping skills are going to work for those different types of stressors and at what different levels of intensity. It's also not a one-time thing. People will be like, oh yeah, I made a safety plan with my therapist. Great, what's on your safety plan? I don't remember. Where's your safety plan? I'm not sure. That's not helpful at all, right? Safety planning is an exercise between two people to think about how do we identify support and reasons for living in your life. It needs to be an ongoing thing. Every single session, if you're doing therapy with someone, you should be safety. Also, not contracting for safety, which has no legal or clinical. There's a sort of classic slightly evidence-based safety plan that was developed for adults, which is what we often use in CCPEP. If you Google Stanley and Brown safety plan, you'll find it. This is just taken from there. One note I would make is that while the safety plan was originally designed for suicide, we use it for any risk behavior. We use it for drug use, we use it for running away, we use it for cutting. Because again, it's just an intellectual exercise in how do I think about the antecedents to my behavior, the things that help me in those moments, and the ways to sort of get support either internally or externally when I need it. So the safety plan looks at warning signs, internal coping skills, social supports, friends or family members, other, crisis helplines, things like that, and then reducing access to lethal means. When we do this, we review it with the family as well, in part because the family is a key support for the child, but also because if the child has written that my coping skills when I feel really suicidal are going to be use my phone and go up to the roof of my building, I don't think any parent's going to let their suicidal child go up to the roof of their building. I mean, if they were, we'd have to address that with them. But also, a lot of kids are suicidal in the context of conflict with their family, at which point their phone has been taken away. So we have to have families be on board of like, is this actually going to work? What's this like? And it also is a, you know, as much as the safety plan is an exercise between the therapist and the kid around safety planning and how do we think about that, the same interaction needs to happen between the parent and the child. So what we typically do is we do it with the kid first, and then we have the kid and the parent work it out, and that's helpful to observe how validating is the parent to the kid, how much is the parent able to think about, like, we're taking this seriously, this is a real issue we want to help our child with, or not. If safety planning doesn't work, right, if there's more suicidal thoughts, or if there's more cutting, or another suicide attempt, you go back to your safety plan. You have to figure out what worked and what didn't work. You can't just say that thing that didn't work is going to still work, right? You have to figure out why did it fail. Is it that you didn't try any of the things? Is it that you forgot it? Is it that you weren't able to do those things for whatever reason? And then involving other supports, either additional clinical help or mobile crisis programs or things like that. Thinking about interventions is really important because there's very little in terms of evidence-based interventions, particularly for youth, but even for adults, that really target suicide risk. We have sort of thought as a field of suicide as a symptom that is secondary to depression or anxiety or whatever, so we treat the depression or the anxiety or whatever, and then the suicidal thoughts will get better. But we don't really know if that's true, particularly in adolescents for whom I at least think that there's a lot more impulsive suicidality in the sense of, you know, kids feeling trapped or feeling burdensome or whatever. And also we don't necessarily want to wait for the 6 weeks for the SSRI to work or for CBT to kick in. So there is some for adults, CBT for suicide attempters. DBT obviously is amazing, but very hard to access, particularly in the city where you have to have a lot of money, a lot of money. CAMS is a collaborative, I forget what the rest of it is, something, is a great model that has been developed. We're starting to do that at NYU. It really is focused specifically on suicide and looking at the antecedents to suicide and how we're going to figure those things out together. That's the collaborative part of it. But I think in the absence of one of those sort of organized treatment programs, that's where we come back to needs restriction. I spend a lot of time talking to families about like how exactly we're going to lock these things up. Can you put a lock on the door to your terrace of your apartment? Can you get the super to come in and put window guards? Where are the pills locked up? Lock up the pills. Wear the key around your neck. Wear it while you're sleeping. Don't just like leave it in a drawer and assume the kid doesn't orders, because kids know where everything is in their house, right? They spend their time canvassing their parents' stuff and like looking for hidden money or porn. Like they don't, they're gonna find the key. The key has to be like on your body. So we spend a lot of time thinking about that stuff, and then really working on enhancing social connectedness within the family, within the school, any supports that we can find for that kid. Sometimes it's online. We'll take that. We'd rather something in person. I really like chain analysis, which hopefully you guys know a little bit about, maybe not. I think there's an example of it in a moment. The idea is, sort of going back to that earlier slide about cutting, the idea is suicidal thoughts are not something that arises out of nothing. It is there is a predictable pattern to all of our thoughts and behaviors because we are, you know, creatures of habit. We may not be aware of those predictable patterns, but the way that we can become aware of them is through an excruciatingly boring and painful, detailed analysis of every single step. So in DBT, from which this was originally adapted, they use it as a sort of like an aversive thing for self-injury. So if you're in DBT and you go to your therapist and you're like, yeah, I cut myself, they're like, oh great, now I get to do a chain analysis. And the kids are like, but I want to talk about this thing that happened at school. And the therapists are like, well, we have to do a chain analysis. So it works for that. But it can also be used as like an actual clinical tool. It does not have to be quite so excruciating. But the idea is in really granular detail, what happened, how did you think and feel, then what happened, how did you think and feel, if kids have a lot of self-awareness, you can go forward in time, right? So like the night before, what was going on, that morning, what was going on, how was school, da 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 da. When kids don't have a lot of self-awareness, we go backwards. So, okay, so you cut yourself, where were you? Or you were having suicidal thoughts, where were you? What exactly was the thought? What happened next? What happened before that? What happened before that? And you're both doing the exercise and modeling that a little bit of metacognition, right? That like thinking is a thing that we can think about. It is not, thoughts and emotions are not things that we have no control over, that just become us, and then we are like the Hulk and have no control. So yeah, so this is what the chain analysis would look like if you were to draw it out, which is often what we do. So you can see the behavior in the middle, that would be either the suicidal or the self-injurious behavior, and you look at what were the thoughts and feelings before that, and also what happened after. Oftentimes, I have like 3 kids in the ER right now who are like, the thing that's going to keep me from killing myself in the future is the fear of coming back to this ER and having to talk to all of you assholes. That's fine. I'll take that. That's great. If that's going to help them stay safe, if the idea of like, okay, I need to, not get back to that ER, which I weirdly didn't like, that's fine. On the flip side, if it's, my family has really come together in the wake of my saying that I was suicidal, and they have been supporting me in a way that they never were before, that's lovely, but also kind of worrisome. Because then, if that support ever dissipates, the kid's going to be like, what really helped bring everyone together last time was when I talked about suicide. So we have to think about what are the social and practical reinforcers of these things as well. Family interventions are really important, especially for kids and adolescents, but probably for adults too. One of the ideas that I really like is that that comes from our DBT team uses is this idea of a boiling point. Because families will talk about, I think this is yes, so families will talk about how it goes from 0 to 100 in a second. But it doesn't, right? The idea is that you get to your boiling point, and by the time, once you get to your boiling point, you've sort of lost control. So it may be that when it gets to your boiling point, it's going to go to 100, that it's going to be really, really difficult, if not impossible, to keep yourself from cutting, from cursing at your mom, from blocking out the door, from taking pills. But going from 0 to that boiling point is not an automatic or unpredictable process. And so we try to, using basically that kind of a chain analysis with the family and the kids together, to think about what are the immediate and more distant triggers that get kids sort of along that line. Because oftentimes what parents will say is, well, she says that she overdosed because I told her that I yelled at her for not doing her homework. But I have to be able to yell at her for not doing her homework because she has to do her homework. And if you tell me that I can't yell at her for not doing her homework, then she's never going to go to Harvard, so like that won't work. But we can help parents to think about, if you got home from work and your partner yelled at you, your response to that is really going to depend on what kind of day you had. If you had a shitty day where your boss was already yelling at you all day, it's going to be much harder to get home and hear it from your wife than if you had a really good day where you felt relatively competent and you get home and you're like, yeah, what, honey, you're right, I did leave those dirty dishes in the sink. So helping them think about how do they read their kid, how do they check in with their kid, and feel more able to get a sense of where their kid is on that stress level. And then it helps them start to recognize that it isn't 0 to 100, that they can get a sense of where their kid is in terms of that initial stress level, and then choose, like, is this the moment to pick a fight with them about their homework? Is this the moment to tell them to do their chores? Or is this a moment to be like, hey, honey, you seem like you're not doing so good, do you want to talk about it? And then later come back to the homework thing, right? Kids have to do their homework. I'm not going to fight about that. But it's about knowing the time and having, again, a better sense for the parent and also for the child of how do I understand myself and my own reactions, how do I understand my kid and their reactions, and how do we have this relationship go better? And so the idea being that if you see your kid starting to escalate, or for kids themselves, if you see yourself starting to escalate, how do you take a detour from that? How do you say, I need a break, we're going to come back to this conversation. And then really do that, which is great. So we often make people have written agreements. Again, this is similar to a safety plan in the sense that it is just an exercise, right? You can't legally hold people to this. But what's I think important about this is it sets an intention for everyone in the family. It has some accountability for both the child and the parent. which is magical to children. The idea that we as adults are going to hold other adults responsible for doing something and ask other adults to change instead of just blaming the children all the time is like, that's helpful and builds some rapport. But it also gives you something to come back to with the family if there is another episode. Did you guys take a break? How did it go? What made it hard to do that? And it's not about yelling at them for doing it wrong. It's about teaching them that behavior change is hard for children and for adults. And so if we want our kids to change, we need to be empathic to how hard it is to change. If we want them to stop going to suicide as a coping strategy, we need to stop going to yelling as a coping strategy, right? And all of those things are hard, and we can be empathic to how hard it is and also hold everyone accountable for change. We also try to build some foundation into that relationship, because oftentimes when kids are dealing with suicidal thoughts, especially chronic suicidal thoughts, or when it's happening in the context of depression or anxiety or school problems or other behavioral issues, there's a lot of strain in the family. Even just finding out that your kid has been having suicidal thoughts and maybe didn't tell you is a huge strain on families. It sort of shakes everything that you thought about yourself as a parent. And I have been amazed at like friends of mine who I think of as being very present and mindful and empathic people who are like, no, my kid doesn't feel it. Because it's just too painful to think about as a parent. So recognizing that there is going to be this strain in the relationship, how do we build that foundation of connection, of attachment? GIVE is an acronym that comes from DBT. Acronyms are helpful. But the idea is like any small positive things, praise, validation, any positive experiences that we can give. And recognize, and helping parents recognize that just as for a therapist or any other adult who that tension in their body and in their face when a kid's talking about suicide projects something to the kid, parents who are projecting, I'm super stressed right now, even if it's, I'm stressed because I don't know how to help you, my child who I adore and who I really want to help, and I feel inept as a parent. Kids don't see that in your mind, because our minds are opaque to others. They see they're mad at me, they're ashamed of me, and that reinforces those thoughts about burdensomeness that can be so dangerous. What's the role of the ER? Sadly, in most places, not much. So Mark Olfson and Jeff Bridge have done some really cool work looking at Medicaid, or depressing, I guess, work looking at Medicaid claims data to see what happened to kids who made a suicide attempt. They call it deliberate self-harm, and it's basically a suicide attempt because of claims data. They don't get coded as suicide, but whatever. They go to the emergency room, what happens? So 39% of them get any kind of mental health assessment. That's not even half, that's pretty terrible. They found that youth who are of Hispanic background get this even less, probably partly because of lack of Spanish-speaking clinicians, but also racism. And that the biggest predictor of getting a mental health assessment is if you were already in outpatient treatment, which means that the kids who are most vulnerable were already missing. And the ones who were discharged, it's not like, or the ones who didn't get a mental health assessment, it's not like someone was like, oh, we don't even need to do the assessment on this kid because they definitely need all these services. They didn't get set up with anything particularly. So we have this specialized psychiatric emergency room. UCLA has one, also for children. That's it. That's all of the psychiatric emergency rooms for children in the United States. That's crazy. You guys probably can't totally see, but those gray blotches, those are the high-level trauma centers for children, because accidents is the other really high cause of death. So as a society, we've recognized that accidents and physical trauma is a huge issue, and that children are dying because they didn't have good emergency doctors who knew how to deal with that close to them. So we built all these really great trauma centers, but we have not done the same thing for psychiatry, unfortunately. So we see, these numbers are old, I apologize. I think we've seen like 10,000 or 11,000 kids now. We see about 2,500 kids a year. This is a picture of our space. We've tried to make it look relatively nice. If you think about the experience of, has anybody been to an emergency room in your life? Some people. Did it suck super hard? It's really bad, right? Like, you wait for a long time, you get seen by a bunch of random strangers, It's often on like a gurney, maybe with a curtain. Sometimes it's in a room with like a bunch of other people around. Imagine that, but for mental health. You basically what happens is like it's the same thing except you have what's called a sitter, which is often a security guard who's watching you, even when you go pee, to make sure that you don't try to kill yourself. So like you can understand why they have that, well intentioned, right? But like that's creepy. Nobody wants that. You wait for even longer for any kind of mental health person to see you. It's a really unpleasant experience of mental health. A lot of kids end up being seen in adult psychiatric emergency rooms, so you're there with like all the alcoholics, all the smelly old homeless men who are mentally ill. That's it's scary, kind of sucky. Or you get seen in the pediatric ER where like the person next to you just got hit by a car or is having a seizure or whatever. That's also not great. So we've tried to make it a little bit more of a pleasant space. It's way too small, as Christine and our eyes would say. So we have a lot of space constraints, but we have private rooms where people can talk. You're not talking with the curtain and then like someone who might be your school classmate right next to you. And we have a sort of hybrid model where we can keep kids for observation for up to 72 hours or admit them for a longer inpatient stay if needed. And we also have the capacity to bring kids back to see us for follow-up appointments because we've discovered that probably like 60% of the kids who come to see us aren't having necessarily like a crisis that requires inpatient hospitalization, but their crisis is something where they need help quickly outside of the hospital, but can't get it because it's really expensive to get decent psychiatric treatment in the United States, in New York specifically, but also I think broadly in the United States. And also there's really long wait lists for mental health, and also because most of outpatient mental health is so this speaks a little bit to the kinds of things that happen. So kids come in, they get evaluated, we decide to admit them in that blue box to our inpatient unit, admit them at that orange box to stay with us for 2 or 3 days, or we discharge them, which is this bottom box, and then have them come back for a crisis clinic. Sometimes they go for observation for a little bit and then get discharged and then come back for a crisis clinic. But the idea is that if most emergency rooms are stuck with either we admit you to the hospital or good luck to you, which is really how it is in a lot of ERs, we want to have the flexibility to be able to give people what they need. So we have people where we discharge them and see them the next day for an outpatient appointment. Or we have people where we follow them every 2 weeks for 6 months and give them ADHD medication. So it really depends on what the kid needs. This is just a little bit about some resources. You guys have access to a lot of this stuff already. I really like the Ask Toolkit. I think it is accessible and easy to use. I don't love the CSSRS. Don't tell your colleagues who developed it that I said that. And then CAMS and the DBT visual textbook websites. These are some books that I helped edit, both of which talk about suicide. The Helping Kids in Crisis talks about managing all different types of psychiatric crises, suicide and self-injury being one of them. And Beyond PTSD talks about helping kids for whom trauma is underlying a range of psychiatric symptoms again, of which suicide and self-injury is one of them. So I hope that was helpful. I did pretty good on time. Yeah.